Gastrointestinal Endoscopy or Oesophagogastroduodenoscopy or OGDS. The learning objectives are listed here, and the pre-OGDS patient preparations are listed here. When we pass the scope through the mouth, the first structure that we see would be epiglottis on the upper part or 12 o'clock, and the base of the tongue will be at 6 o'clock. When we pass through the epiglottis, then we will notice the next structure including the vocal cord, the arytenoid fold, and the piriform fossa. We tend to intubate through one of the piriform fossa as is demonstrated here. Most importantly is to feel a give rather than to push the scope through. Once we enter into the esophageal lumen, it will be a long muscular structures. As we push down further, it will be the gastroesophageal junction. After the gastroesophageal junction, we will enter into the upper part of the stomach, and we will notice saliva or other liquids, and we will need to suck out the liquids to prevent aspiration as well as to clean the saliva. We tend to add Simeticone to reduce the bubble. We entered further, and now in the antrum we will notice the presence of gastric ulcers at the 11 o'clock position as well as the 5 o'clock position. As we proceed the endoscopy further, we will notice an opening called the pylorus, and just above the pylorus there is a gastric ulcer, what we term as a pre-pyloric ulcer. We tend to go nearer to the pylorus, and we can see the ulcer much more clear. As we attempt to intubate the pylorus, sometimes it can be tricky. We need to put a constant pressure on the opening, and sometimes we may need to flush with water. And once we enter the pylorus, then it will be the first part of the duodenum. In the first part of duodenum, the first surface is smooth and granular looking, very similar to the antrum. You will notice here there's an ulcer at the junction between first and second part of duodenum. As we pass through into the second part of duodenum, we tend to see more folds, and occasionally you can see the papilla, the duodenal papilla where the bowel will be excreted. We are now back into the stomach. In order to go into the fundus, we tend to identify the incisura first, which is the angle between the antrum and the body. And on retroflexion, where we will then see the scope on the upper part, we will also see the folds at the greater curvature as well as the lesser curvature where there are less or no folds. Again, we are performing wash and also suction to take out all the liquid in order to see the mucosa more clearly. Now we are able to see the fundus using what we term as the J maneuver, and we are also able to see the gastric cardia where the endoscope passed through. Next, we then now back into the antrum, and since we have seen the ulcers, we will need to perform biopsies to detect the presence of Helicobacter pylori. Through the biopsy channel, there is a forceps where we are able to take a small bite of the mucosa. We are taking a second bite of the antral mucosa. Now after the biopsy, there may be slight bleeding, but it tends to stop spontaneously. After the biopsy, we are now withdrawing the endoscope proximally and now into the gastroesophageal junction. In the gastroesophageal junction, you will notice the Z line. In this case, it is irregular because of the presence of reflux esophagitis. Esophagitis is inflammation of the mucosa as a result of reflux from the stomach content. What I can see here is the narrow band imaging where there is two lights being enhanced, the green and the red light, and it helps us to see the esophagitis more clearly. Now we are on the way out withdrawing the endoscope, and during the withdrawal we will look again at the esophageal mucosa closely, also look at the peristaltic wave, and now we are already out from esophagus. So do take care of the post-OGDS patient care, and that's it. Thank you very much for watching.